Hey everybody, today we're going to talk about blood disorders and their significance in dentistry for us. So let's get started here. Let me see time my video. Okay, so blood disorders, what are they and what is the significance in dentistry? So there's a lot that we can see. There's different types of blood disorders, from red blood cells to white blood cells to clotting factors. So what are the significance for us? So we can oftentimes see oral tissue changes, lowered resistance to infection. And that's kind of where we've seen with everything so far. Any type of disorder that somebody may have will likely lower their resistance to infection, and same with blood disorders. Bleeding tendencies, so obviously maybe we'll see more bleeding, exaggerated responses to local factors. So tissue may start bleeding with just by looking at it. That's when we really get concerned. Why is the tissue bleeding? For no reason at all, especially if they have good home care and there's not a lot of plaque and it's just bleeding randomly. And then also it can lead to a detection of unknown conditions. So a lot of times, if the tissue is just randomly bleeding, it can be a sign of leukemia. And that's not something that we want to say to the patient, but we might say, I'm kind of concerned with what I'm seeing in your mouth here. Have you had blood work done recently by your doctor? And then we would suggest that if they haven't, then they would do that. So possible indicators of a blood disorder, which is kind of what we were just talking about too. So gingival bleeding, a lot of times it's out of nowhere. Post-op hemorrhage, where you just can't get them to stop bleeding. They might have history of bruising easily. So that's the ecchymoses. The petechiae, which are those little pinpoint bruises. Pallor, so the tissue is very, very pale. Again, that exaggerated gingival response. The papillae may disappear, so atrophy of the tongue papillae, glossodinia, which is tongue pain, and infections that do not respond to treatment. So if they're not responding to treatment, is there more that's going on? And then we may also see severe oral ulcerations. So let's first talk about anemia and different types of anemia. So anemia is a reduction in red blood cells or hemoglobin. It's not a disease, but an indication of an underlying problem or condition. Low red blood cell disorder. So let's start talking about that. So etiology of anemia: blood loss, increased hemolysis, and diminished production of red blood cells. So blood loss, so an anemia too. So if you think of the different types of blood loss, there may be an internal bleeding that's happening. There may be something that a hemorrhage from trauma. This can be associated with heavy menstrual cycles. The diminished production of red blood cells. Sometimes it's due to cancer, but our bone marrow is not making enough red blood cells. So clinical characteristics of anemia, again, it's that pallor, that paleness, weakness, fatigue, faintness. There's not enough oxygen getting to the cells, right? So we don't have enough red blood cells. So because of that, we are not getting enough oxygen to our cells. Dyspnea upon slight exertion. So, you might find that you're tired, really, if you're doing something very minor. And that again is because the oxygen is not getting where it needs to. And so that you're feeling that shortness of breath very easily. And then brittle, flat nails, pale nail beds. We might see poor wound healing again, which we talked about already. So different types. So iron deficiency anemia, which we'll talk about first. Then we have megablastic anemia, where we have, so iron deficiency is our red blood cells are small and they lack iron. And the supplement may stain teeth, as it says, but we're going to talk about that more. Megablastic anemia, so they're large, but they're too big, so they're dysfunctional. And then that's broken down into pernicious anemia and then folate deficiency anemia, which is dangerous during pregnancy. And we'll get into this more too. And then we also have sickle cell anemia. Hang on one second. I'm going really fast, but maybe I don't have more slides on that. So let me talk more then about iron deficiency anemia. So this is an anemia that's our red blood cells are smaller than normal. So because they're smaller than normal, they are deficient in hemoglobin. So it's more common in young individuals and females. So iron deficiency anemia is pretty common. You have to take an iron supplement. You may have patients that come in that are on it that have this type of anemia and they take a supplement, but those supplements may cause staining. So that's something to be aware of and let your patient know. Sometimes it's different supplements may cause staining, so they may try something different, but be aware that if there is, you may see stain on the teeth from it. This here, again, that is the biggest treatment of it is just those supplements, and then to check their blood and make sure that their iron levels are where they should be. Then we have that megablastic anemia. So they're large, which maybe we might think that's better. They're bigger, they can carry more oxygen, but they're too dysfunctional. So they're big, but they're not doing what they're supposed to. So although they're larger, they're not good. Now, pernicious anemia is an anemia where the stomach is not creating or secreting the intrinsic factor, which we need to absorb B12. And B12, along with folic acid, are needed to mature our red blood cells in our bone marrow. So if we don't have enough B12 and folic acid, our red blood cells are never going to be mature enough. They're never going to work the way that they should. This one is usually seen in 40 to 7-year-olds with fair skin complex. And then the signs and symptoms are kind of what we went over, that painful tongue. They may have angular cheilitis, which is that infection in the corners of their mouths, weakness, tingling or numbness, neurological symptoms. They may end up having neurological symptoms if it's not treated. So that's why it's just always good to go to the doctor and have your blood work checked so that they can, your complete blood count. They'll check all of this to make sure that there's nothing lacking. Sickle cell anemia. So this, I remember in private practice, I had a young boy with sickle cell anemia, and it is a hereditary type of anemia in which our red blood cells become rigid and sickle shaped. And because they are sickle shaped, they can't pass easily through blood vessels. So if you think of our blood vessels like almost like an inflatable tube, you're going down, you're at a water park and you're on those tubes and you're going down the slide, right? And it's moving all around, it's sliding up the side, it's squeezing in the tubes, and then you come out the bottom, right? Think of that as kind of your red blood cells. So you want them to be the right size and pliable so that they're moving. I'm using my hands as if you can see me, but so that they're moving through our bloodstream the way that they should be. These red blood cells, think of our sickle scalar, right? That's almost exactly what they look like. So they don't flow as easily through our blood, through our veins. They get stuck. They don't slide in where they should. And it can cause some really painful almost blockages because it's not flowing the way it should. So it's very important that we take certain steps before we see these patients. So the trait is inherited. So one copy of the sickle cell gene, one parent has to have it to pass it to their children to basically be a carrier. So if only one of your parents have it, you may be a carrier, you have no symptoms and you have no idea, but you'll pass that gene to your children. And then if you are a man with the gene and your wife or female partner also has the gene, then both parents have to give that gene to the child to have that sickle cell anemia. So dental therapy considerations. We want to have short appointments, avoid complicated procedures. We want to make sure that we understand too where sometimes they might have like a flare up with sickle cell anemia. So we just want to make sure they're feeling good. We want to give them good home care education. Any infections we want to treat aggressively and consult with a physician. And we never want to use, this is really important, so circle this, we never want to use local anesthetic with a vasoconstrictor. Does anybody know why or why we would want that? But a vasoconstrictor, it's constricting the vessels. If we constrict the vessels and this patient has sickle cell anemia, their red blood cells aren't pliable. They're not going to still be able to get through. And then what'll happen is that'll vasoconstrict. The sickle cells aren't going to be able to get through. So say we're treating, say the patient has an abscess, we're treating the abscess, we're using a vasoconstrictor, but then oxygen and blood flow is not going to get to the site that we're just treated, and it could in turn result in a pretty serious infection. So we want to make sure we're not using any vasoconstrictors. We want to make sure that we're educating the patient to just why it's so important to minimize oral infections, right? Because again, their blood might not get there as quickly as it should or as well as it should. So we want to make sure that these patients are having excellent home care. And I remember the little boy that I treated with sickle cell anemia, that's what we really worked on with his dad. They brought him in every 3 months, and we really worked on making sure that they knew how important home care was and that they could help him as well. Then we have hemolytic anemia, which is the destruction or defective construction of our red blood cells. So this can be acquired or inherited. So if you have a mismatched blood transfusion, chronic alcohol can lead to this, toxins and drugs, immune response disorders, or genetic disorders. And then we'll also talk about erythroblastoma fetalis, which this is due if you've had a baby, there's something called the Rh factor, where the maternal and the baby, their blood types are incompatible, and the mother starts creating antibodies against the baby's blood type. It's always tested for, and it's an easy fix that the mom just needs a shot. But hemolytic anemia is defined as the destruction. So lytic means death and hemo means blood. So basically it's a death of your red blood cells. And that, again, it's most common, I would say, with mismatched blood transfusions. So polycythemia is defined as too much red blood cells, which we would think, great, we have too much, we have more oxygen, this is a good thing, but it's not a good thing. It's an unknown etiology, but it's associated with a chromosomal defect. And it begins with the change in the DNA of a single form of a forming stem cell, and then it goes from there. But you may see the skin and mucous membranes acquire a maroon or plum-like color, and the patient develops an enlarged liver and spleen, as well as other neurological symptoms. Secondary polycythemia results from decreased oxygen supply, so that can be congenital. It can also be from heart problems, right? So think of COPD, pulmonary disease, smoking. That is when our body tries to compensate for low levels of oxygen. So if we remember our patients with COPD, they're not getting enough oxygen. So the body, again, our bodies are amazing, and they try to compensate for that. So they're saying, well, we're not getting enough oxygen, we're going to make more red blood cells so that they can come and get to where we need them to be. But as it does that, they're not, those red blood cells that our body is making extra, they're not working right. So they're there, but they're not doing the job that they're supposed to. So now we're going to talk about disorders of the leukocytes. So leukopenia is the reduction of our leukocytes, right? So it can be a slow production or an increased destruction of our white blood cells. And our white blood cells are important, right? They're our fighters. They're going to come in and tackle all those infections that we're getting. So you may see that we have sometimes when we get sick, we have an increase in white blood cells, but we'll get into that after this because this is on a decrease. But it may result when cell production cannot keep pace with the turnover rate, or when rate of cell removal is accelerated. So certain infections, diseases, destruction of the bone marrow, again, chronic drug poisoning, you may have radiation. And if you have radiation, that may also affect your production of white blood cells. I think that's all I really wanted to say on that. So let's move on to agranulocytosis. So granulocytes are important to our immune system, but agranulocytosis is a disease in which there is a sudden drop in the production of leukocytes. So this leaves the body defenseless against bacteria that comes in, right? Because if you remember back to A&P, we have the different, there's a whole process of when we get sick and who comes in and who, is attacking that bacteria first. So with the decrease or the sudden drop of the leukocytes, it just makes us more susceptible to any type of infection. So signs and symptoms, a severe infection with fever, malaise and weakness, oral ulcerations, gingival bleeding, a bad breath odor, increased salivation. Leukocytosis is an increase in the number of circulating white blood cells. So different white blood cells may predominate depending on the cause. This can be, you may have an infection and you go into the doctor and they're like, oh, your white blood cells are sky high. That's just, they're doing their job. You have an active infection. Our white blood cells are increasing and they're fighting off that infection. So if that's the case, then they're going to monitor your white blood cells and make sure that they come back down to their normal level when your body is, in hemostasis. So when we are fighting infection, our white blood cells go up. But this can also be, if it stays this way, it can be, due to an allergic reaction, inflammation, infection, trauma, but it also can be a sign of leukemia. Infectious mononucleosis. If anyone's ever had mono, it's what I think, didn't they used to call mono the kissing disease? I don't know if they still do, but it's an acute infectious disease that causes a formation of atypical white blood cells. Again, it's headache, sore throat, fatigue, swollen lymph nodes, and then treatment is palliative, occasionally steroids. I think you just have to let it run its course. If anyone has had mono, it really throws you for a loop. I mean, it's like feels like the flu, and you just have to wait it out. But it takes a long time. I mean, you can be in bed for a really long time. It's really painful. I've never had it, but it went around a lot when I was in college. These are what some of those oral ulcerations can look like. Pretty painful. Now let's talk about leukemia. So leukemia is a malignancy of the white blood cells, and there's different kinds, but it's cancer of the white blood cells, and it's characterized by abnormally large number of white blood cells, resulting in an immature form of that circulating white blood cell. So they're not functioning the way that they should be. There's acute leukemias that have a sudden onset and rapidly progress fast, so they need treatment fast. And then there's also chronic leukemias, and these develop slowly. Signs and symptoms to those of the acute forms may not appear for years, and it can go on for years with no problem. So you can live with chronic leukemia for years. My dentist that I work for, he's like, oh yeah, I've had it for years, but has never had a problem with it. It's just something that they have monitored. Signs and symptoms of leukemia: fever, weakness. Again, we see these with a lot of different types of disorders, but bleeding, paleness, recurrent infections, which makes sense, right? Because our white blood cells are not working the way that they should. Lymph nodes are enlarged, weight loss, night sweat. Oral manifestations of leukemia. So they may be detected. The biggest thing to remember is that we may detect it before a patient is even diagnosed. So you may also want to be careful, like I said at the beginning, with your wording, like, oh my goodness, I think you have leukemia. We would never say that. More so, I'm concerned with what I'm seeing in your mouth. When was the last time you had some blood work done by your doctor? I would recommend that you go. I just want to, I'd love to see the results just to make sure that I'm treating your mouth the way that it should be. But they may be having certain signs and symptoms that are effects of the disease, but they may also be having signs and symptoms that are effects of the treatment that they're undergoing. So they may have gingivitis with severe profuse bleeding. And if you've ever seen it in a patient, then you know what I mean. I mean, you can just literally look at the tissue and it's bleeding. Those oral ulcerations, gingival hyperplasia, xerostomia, which is again really common in the treatment. And then secondary infections, we may see candidiasis in their mouth as a secondary infection. And they just really have an increased susceptibility to all infections. So even though they have more white blood cells, they're not formed correctly and they're not doing the job that they should. So dental therapy considerations, we always want to remember that susceptibility to infection. We want to make sure that we treat things immediately but cautiously. We want to delay elective treatment until the patient is in remission. Again, unless it's an emergency, that's why we always want to consult with their physician. So we want to know what their current blood count is. We want to know if they need antibiotic pre-medication. Very strict asepsis, which we do in dentistry, regardless of what is happening with the patient. We want to make sure they're managing their bleeding. We want, this patient may go home and 2 days later you hear that they're still bleeding. So we want to make sure that we're managing their bleeding. We're not just doing a procedure, sending them on their way and say, good luck. But you really want to follow up. You want to make sure that the bleeding is stopped, that they're feeling okay, and you want to be in communication with their doctor. And then again, any post-treatment concerns. They may need, cool liquids, soft diet, straws. Like a lot of times too, if you're drinking out of a straw, that can affect the clot. If you have had your wisdom teeth out, they will say don't drink out of a straw because you can end up with dry socket. So similar like that, you want to let the clot do its job. And speaking of clotting, let's talk about hemorrhagic disorders. So thrombocytopenia is a decrease in the number of platelets. Idiopathic thrombocytopenic purpura is an autoimmune disorder. So our body is destroying our platelets. There's different blood clotting defects. There's acquired, so the vitamin K deficiency, there's liver disease. So common tendencies: spontaneous bleeding, moderate to excessive bleeding after trauma or surgery, and spontaneous bleeding may occur into skin or mucous membranes. So that petechiae, purpura, ecchymosis, you may see it under the skin. So they may have more bruising under the skin because they're not clotting appropriately. Hemophilia. Congenital disorders of the blood clotting mechanism. So there's 3 most common kinds are hemophilia A, hemophilia B, and von Willebrand's disease. I am posting also a separate YouTube video that just reviews again the whole clotting process of when we have a cut. And if we remember from A&P, we learn all about, how the clot forms and how our body will heal after the blood clots and our scab is formed and things like that. So review that video because it's going to do a much better job of explaining that than I will. But just having an understanding of how clotting happens will help you understand the clotting disorders better. Severe hemophilia, this is in less than 1% of clotting proteins. So if somebody has less than 1% of their clotting proteins, they can have spontaneous bleeding episodes and prolonged bleeding after minor trauma. And a lot of times that's even just the first way that you notice that you might have a clotting disorder. And moderate hemophilia clotting factors in the 2 to 5% range, less frequent spontaneous bleeds, prolonged and heavy bleeding still after minor trauma. This is that clotting cascade with, all of these intrinsic factors, extrinsic pathways, our fibrogen, our insoluble fibrin, and how each one plays a role in the clotting cascade. And again, that is in that other video. So review that other video that talks all about the clotting cascade. And our normal clotting factor is, we have a cut and then it, basically plugs the cut, right? So it cuts off blood flow it creates the clot so that we don't bleed to death, right? It's our body's own natural clotting process. A patient with hemophilia, see how, they might have this little block is smaller than the rest. So when that happens, the full clot is not able to form and blood is going to leak through. So hemophilia does not allow the clotting to happen to its full extent, which causes leaking and blood to still continue to come out, as opposed to, it's like dominoes. All the dominoes fall and they block the hole. When you have hemophilia, this domino is too short, it doesn't trigger the rest to fall, and it's going to continue to bleed. The most common symptoms of hemophilia are bleeding into joints, prolonged bleeding from cuts or injuries, nosebleeds, this is a huge one that don't stop, and bruising. Hemophilia A, so hemophilia A has to do with the deficiency of factor VIII. So this is Roman numeral, this is for 5, 6, 7, 8. It's an X-linked recessive trait, and it's also known as classic hemophilia, inherited by males from female carriers. So this is causes of hemophilia. So a father without hemophilia and a carrier mother can result in a son having hemophilia because it's on the X chromosome. The daughter will just be a carrier because it's only on half of her X chromosome. As opposed to a father with hemophilia, it's on his X chromosome, but the mother does not have it, so the son will not. But the daughter will be a carrier because it's on her X chromosome. So in order for a son to have it, the mother has to be a carrier. Hemophilia B is a deficiency in factor IV. It's an X-linked recessive trait, and it's also known as the Christmas disease, and I was very interested in why. It was just the person that discovered it, his last name was Christmas. It was diagnosed by Stephen Christmas. So it's not, something you want to unwrap on Christmas Day, but it's inherited by males from female carriers. This is just a little bit more involved. You will have patients they'll tell you they have von Willebrand's disease. It's the most common bleeding disorder affecting approximately 1 in every 100 people. Men and women are affected equally, but women tend to have more symptoms because of their menstrual cycles. And the bleeding that happens along with that. So dental therapy considerations, always consult with a physician. Factor replacement drugs or drugs given prior to treatment, that's something you want to see what the physician is recommending. Sometimes they need to pre-medicate, meticulous home care, and frequent maintenance visits. This is the biggest thing because if we are giving the gum tissue reasons to be inflamed, plaque, lack of dental care, not flossing, anything like that, if there is plaque, what's going to happen? We are going to get inflammation. If we get inflammation, there's going to be bleeding. If we get bleeding, there may be issues with clotting. So any type of bleeding disorder, meticulous home care is so important because we want to make sure that we are creating a neutral area that is not going to cause bleeding for any type of reason. So the cleaner the mouth, the less likely there will be bleeding. Do not recommend aspirin or NSAIDs. Again, increase in bleeding. And then scaling in small segments, we really want to be careful to avoid trauma on these patients. We don't want to give the body a reason to bleed if it doesn't have to. Aplastic anemia is when the bone marrow fails to produce any of the formed elements of the blood. So aplastic anemia, again, I know we talked about anemias at the beginning, but this is the bone marrow is not producing any elements of the blood. So this results in anemia, leukopenia, and thrombocytopenia. It can be acquired or inherited. It's a neoplastic disease of the bone marrow. This can be destruction of bone marrow by toxins, drugs. You will hear patients that, they have to have radiation. They have to have very aggressive treatment for cancer, which then destroys their bone marrow. And they are then going to need blood transfusions, bone marrow transplants, and possibly steroids. And then if these people end up on steroids for a long time, what can happen again if you think back of a patient that's been on steroids for a long time. So this again is something you would want to consult with a physician and understand why is this happening. A lot of times it will be the result of radiation exposure. So that's why consulting with a physician is always important. And that is it for blood.